people who are involved in the implementation. We also saw the importance of engaging consumers to try to increase demand, or using mass media to make an evidence-based program or policy known to people. We had many examples of this in COVID, where we tried to increase demand by publicizing the importance and opportunity for obtaining COVID vaccines. Sometimes we have to actually change the way we're delivering care. We may need to change record systems. We may need to change the physical location or equipment that we're using. So we change what we call the practice infrastructure. We know that assisting providers and clinicians is also important. So many implementation initiatives are greatly helped by actually a complex implementation strategy called facilitation. Also providing local technical assistance or direct clinical supervision. All these are within that category of providing interactive assistance. Certainly developing stakeholder relationships. I talked earlier about identifying and preparing champions, identifying people who are eager to adopt something new and shining a spotlight on what they are doing. Certainly supporting clinicians with reminders, helping relay clinical data. And then finally, another example that I briefly touched on, using financial strategies, actually paying people to deliver better care, paying them a little bit more, finding new funding to support the delivery of a new intervention or program, or for changing the infrastructure. So these reflect the 9 categories that we established in our ERIC compilation of implementation strategies. And we hope that these articles are useful in helping people consider what approaches they might draw on. How might you actually change your practice setting for the better by using some of these strategies? This has been adopted pretty widely. It has helped promote a common language and improve the reporting of research. And these strategies and these compilations have been endorsed by a number of major funding agencies. The ERIC survey, which is a tool to use to identify, to assess, to measure the strategies that are being used in a particular location. This has been widely adopted in a number of fields of practice. Certainly hepatitis, liver disease. Sherry Rogel and her team have been very prolific, very active in writing articles that show how to actually measure the strategies that are in use in real world practice. There have also been widespread applications of the ERIC strategies in schools, in mental health, and in financing of behavioral health. And I hope these papers might be useful to you in identifying some examples. We have work currently underway to identify the fit, to understand how applicable the ERIC strategies are in low and middle income countries. And this work is ongoing. I'm part of a team with Kate Lavero, where we are mapping the strategies used in low and middle income countries. And as soon as I finish my presentation, you're going to hear from Dr. John Olawepo on the application of implementation strategies in Nigeria. So I want to pause now and invite some questions. Actually, I see a question. one from Dr. Greg Ahrens. Hello, Greg. It's good to see you. Dr. Ahrens is posing the question, how does a strategy like public recognition fit into the idea of organizational or clinical level climate? Greg, I'm wondering if you have some thoughts about this, and if it might be possible to invite you in. I'm happy to share my thoughts, but this is a question that suggests you have an idea in mind.
Can you please move Dr. Ahrens from attendee to panelist? So if you want to speak.
Okay. Yes, he will be moved by Amaka now.
Yeah, I think I was just moved. So thank you. Great to see you, Dr. Proctor, and everyone else. So my question was just prompted by this idea of, what's the prevailing kind of sense of the support for specific evidence-based interventions in a given clinic, in a given hospital. And so the idea of recognition and support is, at least from my perspective, is part of the climate of the organization. Mm-hmm. So all of the things that an organization might do to communicate to employees that the implementation of a specific practice is expected, supported, and recognized as important, which was laid out by our colleague Brian Weiner and Catherine Klein earlier than that. So this idea of creating a context, and I know Dr. Proctor, you talked about the importance of context in all of this. So it's the idea of how do we shape or develop the climate in a given context, like a hospital or a clinic, that really communicates the importance of that initiative.
Yeah, thank you. Thank you for that. And to our participants, you will have time later in the week to learn from Dr. Ahrens, who is really the leading expert on organizational leadership and fostering the kind of culture within an organization that supports and encourages the delivery of evidence-based practice. And I can give a few examples related to that, and I'm sure he will have more later in the week. I visited an agency and spent quite a bit of time in February of this year with an agency in South Australia. And they actually had a lot of motivational posters on the wall for the staff to see that reminded the staff that their value is to deliver high quality evidence-based care. I once was fortunate to work with the dean who said, our values need to be on the wall. What we value in an organization, and in our case this week, as we consider the delivery of evidence-based interventions, a value might be that we are delivering this particular high-quality care. Certainly, some agencies are recognized by their local communities, or champions within an organization can be recognized and called out. This is actually the intention of accreditation or blue ribbon agencies, where the agency has a lot of internal support and pride in the fact that they are delivering particularly good care, or that they are the go-to place for a particular intervention. They want to be known in the market of other agencies as the best place to get a particular kind of care. I was very excited when, for a number of years, a behavioral health patient and family group called NAMI, the National Alliance for the Mentally Ill, had on their website, your loved one with mental illness deserves evidence-based care. Ask for it. And agencies that can respond and say, yes, we deliver the most effective care. that kind of promotion and support, and in the language Dr. Ahrens was using, that kind of climate that a clinic or an organization can foster is really an important strategy to help ensure that good care is delivered and continues. So,
Yeah, Enola, you have a number of questions here.
okay.
Okay, so this one says, this is from Chukwebuka. It says, did the ERIC explicitly engage end users as part of the experts, in other words, as co-developers, not within the aim of demand creation?
Excellent question. And yes, that is actually, the first compilation that we published in 2012 did not engage those implementers or the people who are delivering, but that's exactly what we set out to do and did do by engaging the experts. We called them the experts, the people delivering the intervention. And so, yes, the ERIC compilation was co-created between our team, between researchers, and between those who are actively implementing with a great deal of expertise.
Okay, thank you. Kudus Lawal is saying, thank you for the lucid presentation. And he's asking, can implementation science be integrated into original evidence generating research?
I love this question.
Yeah, the intersection between translation and implementation science.
Yes, terrific questions. I really love the first question. Can implementation science be integrated into original evidence generating research? The answer is yes, and it should be. And we are learning some ways to help make that happen. There is a kind of research design that, again, my colleague, Dr. Jeff Curran has, and many collaborators have helped disseminate through their publications on hybrid trials. And the hybrid 1 research design is intended to precisely address the point raised by the first part of this question, so that while we are testing an intervention, we're also gathering evidence on what are the barriers, how much time does it take to deliver, how do people respond to it, is it acceptable? And by carrying these important implementation questions into the original evidence generating research phase, that is testing the effectiveness, we believe this will accelerate our ability to move more squarely to implementation challenges, specifically into the testing of strategies. And actually, both parts of this question are related, because the intersection between translation and implementation science, this is a little bit of jargon separation that we find. In Canada, implementation science is called knowledge translation. In the broader area of research translation, we span the entire research generating process. So implementation science is really all about translating evidence into use. So thanks for those, for both parts of that important question.
So while we're just waiting, Enola,
yeah, sure.
Oh, go ahead if there are more questions.
There are more questions. So Minani is asking, what are the factors that can influence how well a policy or intervention is implemented? And the second part of that question says, what is the association between health outcomes, that's effectiveness of a policy or intervention, and how well it is implemented?
Really important questions. And I will acknowledge I am not the expert in policy implementation. It has been an understudied topic, but one that fortunately is getting more and more attention. I will point you to the work of a colleague of mine, Jonathan Pertle, P-U-R-T-L-E, Jonathan Pertle at New York University. And he specializes in studying how well policy interventions are implemented. He has found a number of factors, including political orientation. And one of his first papers in this field of inquiry that I was involved in involves surveying policymakers and trying to understand how well they understood evidence-based policy and what factors were associated with their support for that. Certainly their constituent support for it, the visibility of a policy, some of the same strategies that influence how organizations change are believed to influence how well policies are implemented. For example, there is a mental health or behavioral health organization in the United States that publishes a report each year called Grading the States. And for all 50 states, they assign a grade as to how well that state is doing at implementing evidence-based practices. So in a sense, they're using some of those strategies to shine a spotlight on a well-performing state and to promote them and to give them some recognition. So I'll refer you to Dr. Pertle's work for a better understanding. It's an excellent question. I'm very enthused about the increased involvement of policy implementation researchers, and I hope that you are conducting that and that we'll have opportunity to learn from your inquiry into this important issue. The second part of that question is, what is the association between effectiveness of a policy or intervention and how well this is implemented? Well, we certainly wish and we hope that interventions that are effective in achieving health outcomes are implemented well. Sometimes that's the case, sometimes that's not the case. I think we can look to our not too distant past with COVID. We knew that the vaccines were effective. However, that information, that awareness did not seem to ensure widespread implementation of the vaccine because other things got in the way. I believe that at the heart of this issue is how much people, first of all, know the effectiveness of given interventions and value effectiveness. Unfortunately, we seem to be in a time when evidence is often discounted. We're in an era with increased, I hope it's short-lived, but increased distrust of science. And when we have widespread distrust of the scientific process, we're going to undervalue evidence, and therefore that is going to make it more difficult to ensure that effectiveness really facilitates implementation. So I want to be optimistic, and I am optimistic. I'm a person who believes that the more effective something is, the more widely it will be adopted. I've seen this in my own research, research involving social service settings where there are huge challenges, where there's lack of funding, where there is a belief and kind of an acceptance that people who are living in poverty, living in social isolation, would be depressed, and therefore a reluctance to adopt evidence-based interventions for depression. However, in this project, when we could demonstrate through an experiment that people who were in poverty, who were socially isolated, could have an improvement in their depression through certain depression interventions, we did find increased acceptance among those previously skeptical or doubting providers. So I personally believe that if we value evidence and if we value effectiveness, that should facilitate the more widespread and the more effective implementation.
Thanks, Enola. And there's this question from Chupebuka. It says, do complex interventions always fit within just one category of accumulation, amplification, convergence, or facilitation? Or can various aspects of such interventions cut across more than one category?
Yes, thank you for that. And indeed, we are finding that most real-world implementation seems to involve the use of multiple complex implementation strategies. In some studies that we have done, we have found that adopters may use up to 25 different implementation strategies. Similarly, our colleague Sherry Rogel has found huge numbers of implementation strategies being used in the real world. So the short answer is yes. Implementation strategies in the real world are typically multiple, and they typically cut across more than one category. Now, we might ask some questions about why is this? And there are two possible answers, and I have colleagues that we love to debate this. One possible answer is that implementation is that hard. It takes a lot of strategies applied at once. Another interpretation of that finding may be that we don't know which ones are most effective, and therefore we are a long way from what we might call precision implementation in knowing what strategies are going to be most effective. And so this conundrum, this puzzle about, do we need all of these implementation strategies? Maybe yes, maybe no, because we're just trying everything that we can think of. That the answer to that dilemma needs to be sorted out through some very complicated kinds of research using adaptive designs or most strategies. I think you're going to be having some sessions later in the week about research designs. So at present, yes, we're using lots of strategies, cutting across multiple strategies. Will we learn more that tells us how to streamline and make implementation more parsimonious or more precise? Perhaps. We have to stay tuned in order to get the answer to that question.
Yeah, thank you, Enola. Can you go ahead with the rest of your lecture? We'll take the questions.
Yes, I will. Yes, I will. Thank you. Thank you for those excellent questions. I really appreciated them. Actually, the last strategy, which was something about co-designing or making sure, I'll briefly talk about some of the challenges in fine-tuning strategies for local context. I credit my colleague, Dr. Powell, for this lovely slide. You know, when you're trying to decide what strategies to use, many people use what we call the train and pray. We teach providers, we teach organizations a new approach, and we hope or pray that it works. Other approaches involve the kitchen sink. And I was alluding to that. The kitchen sink approach means everything we could possibly get our hands on, we throw it into the mix and we apply it. At the other extreme, we may have a one-size-fits-all, where all these animals are trying to find something that fits them all. And we see this approach with people who are promoters or advocates of a particular kind of implementation strategy. And they are seeking to understand how widely it may fit a whole variety of circumstances. And then finally, we have the approach, well, it seemed like a good idea at a time, where we just think, well, I thought it might work, so that's what I used. So these have been historically the kinds of approaches we've used to picking a strategy. And too often there's been little connection between the problem and the kind of implementation strategy that is chosen, and especially organization and system related and contextually appropriate factors have tended to be ignored. So there is work that I call your attention to, a number of newer publications that are laying out priorities for understanding and improving our knowledge of implementation strategies. And that is enhancing methods for designing and tailoring to particular contexts, specifying and testing mechanisms of change. In other words, we may know if a strategy works, but we may not know how it works until we test the mechanisms. Certainly improving the tracking and reporting of strategies, conducting more effectiveness research, and understanding how much a given implementation strategy, what might its economic impact? Is it going to be too expensive? And I am going to move ahead a little more quickly so that hopefully we'll have time for some more discussions. Certainly, when we are tailoring implementation strategies to a particular context, we need to pay close attention to how we're defining that strategy, what stage of the implementation process is being used, the methods, and the timing. We've identified a number of methods for designing and tailoring strategies. In this first article, we identified concept mapping, which is the approach that underscored the ERIC compilation. There's also group model building, where we get consumers, stakeholders, people who are deeply involved in the implementation together, and together we build through group input the implementation strategy that we think may be most appropriate. Intervention mapping, and I have some slides about intervention mapping, and then conjoint analysis, where we're pitting implementation strategies against each other. Another extremely valuable paper is this methods for designing interventions to change healthcare providers' behavior, a systematic review. An excellent resource for intervention mapping. Many excellent resources can be found in the work of Maria Fernandez. This is a key article, kind of a pivotal article of hers, implementation mapping, using it to develop implementation strategies. I'm going to move on in the sake of time and pause in a few minutes for more questions after we discuss a little bit in evaluating implementation strategies. So it's really important, if we are committed to evidence-based practice, to not only select the interventions, programs, and practices on the basis of how effective they are, but also to select our implementation strategies, considering how effective they are. And in the past decade, we've seen a huge increase in the number of research studies that have evaluated the effectiveness of several strategy types. And this slide depicts an assessment a couple years old of the state of the evidence around 7 categories of implementation strategies: printed educational materials, educational meetings, outreach, using local opinion leaders, audit and feedback, computerized reminders, and tailored interventions. And we can see that the number of trials varies widely. and that we're getting, some degree of improvement. So the short story for this is, first of all, here are some resources for you to dig into the literature to learn more about the effectiveness of certain strategies, but also to take a quick, glance at where we are with knowing the effectiveness. Now, in the United States, one of the major funders of research in the area of implementation is the National Institutes of Health, and the National Institutes of Health is currently prioritizing rigorous research on the study of mechanisms. And what do we know so far? Here is an article that is a systematic review of randomized controlled trials using implementation strategies. They identified 9 studies, 16 different mechanisms, in other words, pathways or ways in which the implementation strategy actually operated. And one of those trials was partially supported by the evidence. More recently, Kara Lewis and team provided us with a systematic review of studies looking at mechanisms in all areas of health. They identified 50 studies, but they didn't meet, nearly half the studies met only 2 of the criteria for establishing causal mechanisms. So we're a long way from actually knowing how implementation strategies work in terms of a robust body of evidence, but this work is underway, which is really the good news. Now, why does it matter? Well, first of all, if we don't understand how strategies work, it's really harder to design and test them. And it limits our ability from studies and the adaptation, replication process, and generalizability. So it's really important that this work proceed. And again, I said there's a lot of ongoing work, including building a database of strategy mechanism linkages, measures of mechanisms, and a website to help disseminate them. Okay, I'm going to talk a little bit about the importance of specifying implementation strategies. In other words, how clearly do we report implementation strategies? In the field of interventions, we're very familiar with manuals or protocols about how to deliver an intervention. Step 1, step 2, step 3. We've done less well, we're making progress, but we need to similarly specify how to employ implementation strategies. So we have advocated that we name it, we define it, and then we specify it by telling who used it. What actions did they take to put this strategy into place? What were they trying to accomplish? When did they use the strategy, and how much of it did they deliver? Much as we might think of the dose of a medication, what is the dose of a strategy? How long do we need to train? How many sessions? How intense? So specifying the dose. Identifying the implementation outcomes that the strategy impacts, and then linking that back to some theory or body of literature, which really is the key to figuring out also the mechanisms for which it works. There's excellent work illustrating how to document and track strategies. And in particular, I refer you to these multiple papers down below. Shout out to Alicia Bunger, a close colleague of mine, and Callie Walsh-Bailey for other reporting of implementation strategies in a way that you can use. These are tools that you can use to actually track strategies. So I'm going to pause now for additional questions, and I'll let the moderators figure out how much time we should spend in this portion of discussion, or I'm hanging around for the next presentation and we can have some discussion at the end of that as well.
Okay, yeah, thank you so much. Thank you so much, Enola. So I think you should hang around so that John will do his presentation. Then the both of you take more questions as they come. Yeah, so thank you so much. I'd like to invite Dr. John Olawepo to make his presentation.
Okay, can you hear me okay?
Yeah, loud and clear.
Okay, thank you. And I wanted to thank Dr. Proctor for the excellent presentation. You know, when you admire someone from afar, having read a lot of your work as an early stage investigator setting out in implementation science, getting to learn from you today and co-present with you today is a great honor. Thank you so much for coming. My duty here today is really very simple. It's more of to contextualize some of the information that Dr. Proctor has been talking about implementation strategies and how they were developed originally in the US and how people around the world have started using them. And in this context, I'll be using this outline. A brief introduction, I'll talk about the settings. That's the context in Nigeria in which we use these strategies and how we develop them. I'll talk about some of the criticisms for implementation strategies and the ERIC project. Then we'll look at one particular case study that we've used in our own local setting and what the results were. Then I'll conclude. Then we'll go back to questions. So when we look at Nigeria, I mean, many of us are familiar with this. Nigeria is located in West Africa, and have 36 states plus the Federal Capital Territory. We have 6 broad geopolitical regions. We have 774 local government areas or counties, as it's called in the US. Nigeria is a very young population. Our median age is 18.6 years. We don't live as long as many other parts of the world. Life expectancy is at 65 or 66 for females and 63 for males. So we still have a lot of work to do in terms of our health indicators. With time, right, we've had a lot of challenges locally, and the Nigeria Implementation Science Alliance set out to try and address some of those challenges. And one of the biggest challenges was the lack of local evidence, the lack of generating local evidence. Many times donors come and go, and there is no sustainable program. So the Nigeria Implementation Science Alliance set out to address that. And we've worked with so many collaborators like the implementing partners. We have 12 to 21 broad-based comprehensive hospitals across the country. We have global collaborators like University of California, San Diego, and other universities. We have policy implementation experts in our team. We have oncology units in our team. And we are continuing to build out this ICON 3 practice-based research network, which we think is the largest network in Nigeria, right? But we think that it can help us generate local evidence for local use. And more importantly is these hospitals, they serve as what we call implementation laboratories. A lot of the work we want to do to generate those local evidence will be done across these 21 hospitals. And we think that those implementation laboratories play a critical role because they will help create an opportunity for us to conduct national studies. And this is the distribution across the country. So the red stars are the 21 secondary and tertiary hospitals. Then the purple dots or circles or spheres are the 6 tertiary oncology centers. And we have the hub at the University of Nigeria College of Medicine in Enugu. So this is our distribution. And one thing you will see distinctly is that we are spread across every geopolitical region in the country. So that is the context. Now let's go back to the ERIC and what Dr. Proctor just described to us, right? There are so many advantages to the ERIC strategies, and Dr. Proctor alluded to many of them. One is that the donors are picking it up, right, and are using it. Another is that they provide a common language for many of us to communicate, right? I know many times having worked in the nonprofit for a long time, we do a lot of these things. You do community engagement, you do a lot of the strategies in the communities, but we don't call it by the names, right, that they are being called. So the ERIC project provides that opportunity for us to speak the same language, right, and name the things that we are doing. So that is very important. And they are also very beneficial for implementation practitioners, especially, that are not doing implementation research primarily, but so that they can communicate in the language that researchers use. There are also criticisms. One of the most common criticisms is that many of the experts were from US and Canada, and the ERIC strategy was developed by people based in the US. Hence, the utility of the strategies outside of that context has been questioned. While people have been able to use it, they've tried to adapt it as best as they can. And there are also that the perception that the context vary widely and some of the strategies need to be changed or used in a different way. Some of the strategies were not explicitly tied to specific theories. And like Dr. Proctor said, a lot of people are doing work around that to try and expand that and address that criticism. We also know that now we have a lot of practitioners using this ERIC project or the ERIC compilation as more of a checklist without putting enough thought into the contextual meanings and implications of those strategies, especially within the local setting where they are working, right? Dr. Proctor talked about one of the things that people do in terms of using one size fits all. For implementation science, it can be more different. The whole essence of implementation science is to take those strategies and contextualize them within the settings with which you work. And our own setting is within Nigeria and essentially within, by extension, to other low and middle income countries. So how did we, at the Nigeria Implementation Science Alliance, how did we use the ERIC strategies? I'll talk about a case where we looked at cervical cancer in Nigeria, how we identified the problem, and how we identified the research gap. And then what did we do about it? So we have always known that cervical cancer is a problem. Is the third leading cause of cancer deaths in Nigeria and accounts for about 10% of all cancer deaths. The cases keep rising, even though we know cervical cancer is very preventable, right? You can give HPV vaccine to young girls and we can prevent cervical cancer. We can identify by doing basic screening, we can identify very early and address it and treat it, right, to prevent cervical cancer. So there are so many things we can do, but people are still dying from cervical cancer. It's a highly, highly preventable cancer. And cervical cancer is now a disease of public health importance, is an AIDS-defining malignancy, and is also a very common cause of death among women that are living with HIV, especially because they are 6 times as likely to develop cervical cancer, and they are more likely to develop it at a younger age. And when women living with HIV specifically get cervical cancer, their treatment outcomes are not as optimal as those who are HIV negative. So because of all of these, right, cervical cancer became an important area of study. And as many of you that work with some of the implementing partners in Nigeria or directly in the hospitals may know, A pilot program was conducted in 3 states, but only 15% of the screening targets were achieved. And mostly, the coverage among women living with HIV was lower compared to that of the general population. One of the key gaps that was identified was that many of the screening and treatment services were rolled out without in-depth thought on contextualizing the knowledge and the gaps and the challenges and how to address them. There were no specific implementation strategies that were documented for the plan, for rollout, for evaluation, for sustainability. So that affected adoption, affected reach, affected sustainment, and limited the entire scope and the achievements from that project. So it was important to take note of that. And the important lesson from that pilot project was that for us to improve cervical cancer screening and treatment among women that are living with HIV in Nigeria, that will require tailored implementation strategies that will simultaneously address some of those barriers, both in the outer context and in the inner context within the clinics. That was a key lesson from that project. So in our group, right, as we began to think about this challenge, we asked ourselves, okay, so what do we do? How do we go about it? So I'll talk about the case study briefly, a rapid implementation mapping to identify the determinants and strategies for cervical cancer control in Nigeria. All of this happened in the context of COVID. And like we know, COVID was this big natural experiment that essentially changed the way that our human interaction occurred, and even interaction between doctor and patient or healthcare worker and patient occurred, right? And here, because of COVID, we couldn't do a face-to-face focus group discussion. So we had to do a virtual implementation mapping process using the nominal group technique. And in that time, we aim to identify the determinants and the strategies to implement this evidence-based cervical cancer screening and treatment. So what did we do? Essentially, we gathered a group of people that were specifically selected. We had 6 program staff from some of the implementing partners that we were working with. We had healthcare providers, including gynecologists and physicians and a nurse. We had monitoring and evaluation officers and record staff from the clinics. We brought them together, but before we brought them together, we essentially sent them a survey in phase 1 and asked them, what are the basic or what are the biggest challenges that you have in terms of addressing cervical cancer screening and treatment among women living with HIV in your clinics or in your programs? Then they send back those surveys. Along those surveys, we also asked them, okay, after you identify these problems, what are some of the solutions or what are the strategies that you think will help us address this? And for us, we know that many of the people who are engaging were not very familiar with implementation strategies or the language of implementation strategies. So what did we do? We actually sent them the ERIC paper, right? The one by Powell and colleagues, and sent them the ERIC paper, asked them, before you answer those questions, please read this ERIC paper. And we met with them, had a meeting, an engagement session where we described the ERIC strategies and what people have used it for previously. And our colleagues, right, they read the ERIC paper, and when they were giving their feedback to the solutions or the strategies that could help address the cervical cancer determinants that they found, they were able to use the language from the ERIC strategies. And we think that was a major opportunity for both learning and cross-learning. Then after the surveys came in and the responses to the strategies to address the barriers, we now had a phase 2 where we had a virtual meeting with all the 11 people gathered. And there we talked and looked at the survey results and we grouped 18 determinants that they sent in. We grouped all of them and put them, we deduplicated them, then we put them together and presented them to the group, right? Essentially, this was the process that we followed. We had, before we sent out the survey, we had picked and selected an implementation science model, which was the EPI strategy that we chose to use. And the needs assessment was done. Then we discussed the determinants. I'll come back to this later. We then, when they sent in the survey, right, we had 18 determinants that we now deduplicated and merged to become 10 determinants. And of those 10 determinants, right, we now ask people to do what Dr. Proctor just mentioned recently about how do we name this and how do we name it, how do we define it, and how do we specify it for both the strategies and the determinants, and so that they will be clearer to everyone that was there. And those determinants that we identified were tied to things like human resource capacity, access to cervical cancer services, logistics issues. And we now asked people and said, using that nominal group technique, and said, can you, right, rank the top determinants, the top 3 determinants? They all ranked it, and we chose the top 3 determinants. Then after that, we asked the next stage, of all the strategies that you've listed, can you match 2 strategies for each of those determinants? So for each of the determinants, they matched 2 strategies, and we now had 6 strategies to address the 2 determinants. Then we went to a next stage and we asked, okay, now we've looked at the ERIC strategies and we've used it to identify these top 6 strategies. What else is out there that we have not talked about? And here, it was interesting to see how we expanded the ERIC strategy, right? 2 strategies emerged. One was the Healthy Beginning Initiative, or as popularly called, the baby shower. And 2 was the use of smart cards for tracking of patients at the point of service. Those 2 strategies were not things that we could put under the ERIC strategies because they were locally generated evidence. They had previously been funded by NIH grants, and having used them, one in the hospital, one in the community, we felt like they were strategies that could be very useful for us. And they were added as 2 extra strategies or as part of the enhanced strategy. And they were very beneficial. It was interesting to see how those strategies came up organically, right? Because they were not among the list of the 73 ERIC strategies, but they were very useful in helping us define how do we solve local problems using local evidence. That was really a very interesting thing to see. And some of the strategies that were identified was the train the trainer strategy, to conduct educational meetings, to involve patients and consumers and families, to prepare patients, to identify and prepare champions, and to inform local opinion. So those were the 6 strategies, and the extra strategies were now the baby shower and the smart card, right? At one point, right, we had more than 8 strategies, but we had to match the strategies together. And we put 2 strategies together to form one, right? And then we had 8 strategies. It was interesting to see the discussions that went on the virtual platform. And we had the benefit of using multiple tools, right? In terms of the kind of technology that was available. We used tools like, of course, we had the meeting over Zoom, but we had communication over WhatsApp. We used the Mentimeter polling app, and all of this virtual NGT session actually happened over 3 hours, but of course, with a lot of preparation that had gone in with the team of experts, both implementation scientists, implementation practitioners, oncologists, gynecologists, and epidemiologists that had done a lot of background work to prep for that meeting. And this was essentially the process we followed, the rapid implementation mapping process, where we identified the implementation science model, and we selected LPs, we conducted needs assessment, and where we prioritized the key needs, and we identified and discussed implementation determinants, right? And that is where we got from 18, then we moved it to 10. That's what we started discussing and voting on. Then we selected the strategies, right? And we came down to 6 strategies, and extra strategies, we now came down to 8 strategies. The process, right, was enlightening. And we felt like it was an opportunity to learn new things about the ERIC strategies, to not only to learn how to use the ERIC strategies, but more importantly, to learn how to expand it for local use, right? Because not everything was in the ERIC strategies, but we felt like there were opportunities for us to expand it beyond the conceptualization that was originally done by people in high-income countries, right? So a few limitations to some of the things we did. A possible criticism was that, okay, we didn't have enough time to give everyone an opportunity to talk extensively, right? Because we had to also move on to have our consensus building and voting and ranking. But despite that, we felt like people had the needed time to expound on some of the strategies that they had proposed. And we actually gave everyone an opportunity to speak before we moved on to ranking and voting. So we feel like it was a very successful process in terms of using the ERIC strategies. And essentially here we outline that it can be feasible and efficient to use the virtual online protocol to address the ERIC strategies and to identify the determinants and strategies for implementing evidence-based cervical cancer screening and treatment within the HIV infrastructure in Nigeria. And essentially, our experience shows that ERIC strategies, they provide a useful framework to guide discussions around how we can use these implementation strategies to both select and how we can deploy them within our local context in low and middle income countries, right? And that has the benefit of helping us expand the knowledge base that we already have. In the final analysis, right, due to multiple things, due to the group of experts that we had in our team, due to the very broad-based and very excellent infrastructure that we had in Nigeria from the NISA mix and the ICON3 practice-based research network, and due to the rigor that went into both identifying the challenges, identifying the gaps, and co-creating the solutions, we were successful in getting the NIH grant, where it runs and Ezeanolu are MPI, and it runs from last year until 2027, a 5-year grant. And that's what we are working on now. And we hope that the lessons that we learn from this project, right, both in terms of cervical cancer, in terms of HIV, in terms of the implementation strategies that actually will be effective in helping us move the needle on getting more women screened, getting more people identified early, and getting them into treatment early, so that the treatment outcomes will be beneficial and very few people will end up dying from cervical cancer. We hope that that will be our contribution to science and to implementation science within LMIC settings. I wanted to thank all those that contributed to this work, Dr. Ezeanolu and Professor Aarons, Dr. Etain, Claire, and Yemi, all of them, and all the IPs, the NISA facilities, and the staff from those facilities. Thank you so much for the time you put into doing this work. In closing, I wanted to mention, right, in LMICs, we have a lot of challenges, but even within those challenges, right, lie a lot of opportunities. And we think in our team, in the ICON3 practice-based research network, that those challenges, as long as we continue to confront them, that we will do amazing stuff, right? And we will be able to address those problems by generating local evidence to solve the local problems. Thank you, everybody, for your time. And I will stop here. Then we'll take questions generally, both for me and for Dr. Proctor. Thank you.
Thank you so much, John. Thank you so much. There's a flurry of questions for you and for Enola. So let's start with you. So Oluwaseun will say, thank you for the presentation. Kindly differentiate the words strategies and interventions as used by implementation scientists, because she sees a lot of overlap in their use in literature. So can you differentiate the two, strategies and interventions?
Okay, thank you so much. So when we talk of the interventions, right, we are talking about the broad-based thing that we want to do, more like what works, what is the, so take for example, for cervical cancer screening and treatment, right? The intervention here is the screening and the treatment, right? The strategies we'll be looking at is, just like Dr. Proctor said earlier from that current article, what makes that intervention, what makes it work, or what can make it work better, right? So if we know that, for example, we need to screen women for cervical cancer, how do we screen them? We can use HPV DNA, we can use VIA, we can use pap smear. But even if those things are available, why are people not getting it? So how do we get more people to get VIA screening, right? That is the strategy. What do we do to get more people to get VIA? So for example, one of the strategies we want to use is to say, we want to go to support groups and we want to talk to them in support groups about specifically cervical cancer. That is a strategy, right? But the thing, the intervention here is the VIA and getting them, those that now have early stage, those that are identified from the screening that need thermal ablation, to get them to get the thermal ablation before it develops into cervical cancer. So that can be an example of a distinction between the intervention and the strategy. I don't know if Dr. Proctor has additional information.
I think, let me go ahead to ask the next question from Dr. Kumba. She's saying, thank you for your impressive work. I was thinking in adding a column between determinant and strategy. It says this is to have a new wording for the determinant for better evaluation. For example, poor access to cancer services could be rewarded. So I don't know if you got that. She's saying that she thinks maybe there should be a new column between determinants and strategy.
Okay, so I mean, what I presented here was a summary. We have a very long table, right? That breaks down what I've talked about into what? Nearly 10 columns, right? So what I presented here was a summary. Absolutely. So what we did, right, was for each of those determinants to identify the strategies we want to use. But beyond that was to specify those strategies. So each of those strategies was defined, right? We named it, we defined it, and we specified it. So each of them had all the things that Dr. Proctor mentioned earlier. Who is the actor? What is the target, right? What is the action? What is the frequency? All of those things we have done, right? So what I did here was to present the summary. So, but thank you very much for that comment.
Okay, thank you, John. You have 3 more questions related to the access grant. So okay. The first one says, from Aisha says, how can we close the huge gap of cervical cancer among people living with HIV and give more enlightenment of the risk of cervical cancer?
So I think to answer that question, right, I want to put it in context. So even the NIH and the WHO know that this is a big problem, especially in LMICs. Currently, we have nearly 4 NIH grants going on in Nigeria. 3 of them are on cervical cancer. 1 of them is on anal cancer. And of those 3, one is we are doing implementation strategies on how to scale up cervical cancer screening and treatment. Another group is doing self-screening for cervical cancer, right? Then another group is testing other things. There are opportunities, right? But why is this important? Is that before now, the evidence, the things we've used is knowledge from outside. And sometimes it just doesn't work as well. But we feel that within this next 5 years, as we do these 3 projects spread across Nigeria, ours is the national study. Many of the others are within some local settings. But when we do these 3 trials, we'll have enough evidence locally, right, to be able to address the biggest challenges that we have for cervical cancer screening. And not just for women living with HIV, but for the general population. Now, beyond that, one of the things that we do differently is that we don't just generate evidence. That's why we have the Nigeria Implementation Science Alliance. And we have our annual conferences every year. This year it will hold August 17 to 18. Sometimes last year held in September. That is the primary platform for dissemination of implementation science strategies and evidence, right? And at that platform, a 2-day conference, but we have the opportunity to actually meet with policymakers, to meet with the government, to meet with the nonprofit sector, to meet with WHO, USAID, CDC. And when we disseminate that evidence, our hope and our plan is that people pick up the evidence that's been generated and now begin to use it in those local settings. And we found that this has been successful in previous times. This time we are working with cervical cancer. We are hoping that we can also achieve that amount of success, right, in terms of dissemination. But beyond the annual conferences, NISA also organizes this NISA Research Week twice a year and the monthly seminars or webinars, right, once every month, right? So there are multiple opportunities for disseminating the information that we have with political will, with uptake by the government, and with support from all the health facilities and the practitioners. I think it's something that we can do to decrease the number of women that are dying from cervical cancer in Nigeria and in LMICs generally.
Okay, thank you, John. I think this question, Professor Zanole can answer. It says, from Sylvia says, what strategies can we utilize to preserve local evidence that is effective in communities, but is not yet formalized as EBIs in the process of promoting implementation science strategies? So, Enola and Professor Zanole, you can take a shot at this question, saying what strategies can we utilize to preserve local evidence that is effective in communities, but not yet formalized as EBIs in the process of promoting implementation science strategies?
Yeah, and I wonder if I might share screen again for a moment.
Yeah,
sure.
Absolutely. Stop sharing.
All right, can you see that slide?
Mm-hmm.
Hello?
Yes,
Yes,
we
we
can.
can.
Okay, great. Yeah, I wanted to build on, respond to that really important question and build on some of the work that John just described. You know, I perceived a need during the COVID pandemic when we all were trying to figure out what could possibly work in terms of implementation strategy. And, you know, we have go-to places to identify evidence-based interventions. We have guideline repertoires, that are developed by various professional organizations, by advocacy groups, by scientific groups, but we really do not have existing repertoires or lists of implementation strategies other than what are in publications. And I believe we have a need for something almost like a wiki developed repertoire of implementation strategies. I felt that, as we monitored how various countries around the globe were trying to promote COVID vaccine uptake, that a lot was happening on the ground, locally based trial and error, and as a result, some evidence about what worked. And yet we had no way to, in real time, capture and consolidate those. So Dr. Ging and I published an editorial in Science magazine, and we said that COVID showed us that knowing what to do did not ensure doing what we knew we needed to be doing, and that something that could really help was establishing a repertoire of proven, and by this I mean both from research and also from practice-based evidence or on the ground knowledge that is not yet reflected in the published implementation science literature about what strategies were used where, for what implementation need, and in what context. So as an example, we had a global group of collaborators who were working with the World Health Organization to develop some materials for online dissemination of what implementation science might offer to the management of the COVID vaccine crisis and lack of uptake. And, we learned, for instance, that, people around the globe were using churches for engagement of community members for vaccine promotion. And, the actor was at the provincial health department with a particular liaison individual whose activities were to try to reach, engage, and educate and motivate pastors. They had conversations with each pastor and had 2 to 4 conversations with each. The action target was to create capability to talk about vaccine in pastors, being aware that there are no fetal cells in the vaccine, and to motivate pastors to say so, and then to support pastors in incorporating three key talking points as they talked about vaccines. So building something like this where we can capture what seemed to work where for what particular implementation challenge, and then establishing a repository of implementation strategies, drawing both on published research but also on the ground evidence to help build that research. It could provide us with some kind of go-to source for information about strategies, a roster of strategies that others have used for what and where, show the varieties of actors, the people who can help support, influence successful implementation, provide information about dose. We got information, for instance, about social marketing in real time. And this evidence came from some areas in sub-Saharan Africa where they were tracking if there is a public radio message broadcast about vaccine availability and the effectiveness and debunking myths about the vaccine, what was the effect on the number of people who showed up the next day or in the next week to get a vaccine, providing information about context and providing information about effectiveness. And then capturing real world evidence. Did the community engagement agents actually reach out to pastors? how often, what adaptations or changes had to be made, the acceptability and appropriateness. How did pastors react to this possible role? Did they find it outside the scope of their mission? Were they motivated? And did they have to get permission from a bishop or somebody to give those messages? And how long could public health agencies maintain the relationships with the churches that they engaged? And did the where there was incomplete outreach, did that vary by other contexts in the community? So establishing those kinds of repositories, it seems to me, are one way. Now, I don't have an answer as to who would support this, where we would launch it, but certainly part of our editorial in Science Magazine was in the Science Journal was encouraging the NIH to help support and fund, or the WHO, some organization that can capture on the ground learning and more quickly make available some suggestions of strategies that might work.
Okay, thank you, Enola. Another question for you. So how can you—
before you go on,
Okay,
I just wanted to take opportunity to point out to on the slide. One of the things we have done every year is to, during the NISA conference, that allow, because we understand that context does matter. And one of the things that we have done, that we've seen, one of the challenges we talked about, the ERIC strategy has been I believe we look at it as much of almost like whatever we do, you can see before that people will gather together, do things that officially will be called a focus group, but there is no, there's no naming it, there's no defining it, there's no specifying. But now we can use those things to define strategies we use. So this conference really offers everyone in Nigeria that is working in implementation space to be present and be able to showcase. You are asking about how do you preserve those things that have not yet been formalized, but this is one place you begin to formalize that. So you're able to share this with all of other people who are implementing, because one of the things we are having a lot in Nigeria is that we have a lot of people who have been implementing things. So think about it, no matter what the study is, no matter whether it's approved by the NIH, whether it's approved by the WHO, at the end of the day, if it's going to be in Nigeria, these are going to be implemented by people who are in Nigeria. And one of the things that happen is that we have a lot of people who have had a lot of experience, 10 years, 20 years, implementing things. So these are very well experienced implementation practitioners. But then there's a gap between them. And then, people like Enola, people like Greg, people like Byron, who develop and actually have these implementation strategies well defined as evidence-based. So that gap is one of the things we try to observe. So that's one of the things we start with, this kind of what we're doing today. How is those implementation strategies, how is those theories, how are those frameworks used in that place? So at the same time, we allow those implementation practitioners to bring in things that have been done, just like what Enola was saying about the use of church in the vaccine during the COVID, to bring those things to light, to share. Yes, this may not have been included in the ERIC strategy, but this was locally relevant, this was locally effective, and be able to share that. So the meeting we have on August 17 and 18 is very important platform for you to be able to showcase the things that you've done locally in Nigeria. This conference has been held with NIH since 2015. This year is actually going to be held in collaboration with the NCI, the National Cancer Institute. They are going to have their investigator meeting August 14, 15, and 16, and they are going to stay back to join us in the conference on the 17 and 18. Registration on abstract submission ends June 30th. So if you have a chance and you're working on implementation science, this would be a great platform to showcase your locally generated evidence, which you may not have formalized, which you may not have published. But this is, first of all, for you to present that in abstract, get input from people locally in Nigeria. Even before you go to international meetings to present it, you may get very good input from other people in Nigeria who may understand the context where you're working. I just thought this was an appropriate time to share this. Please try and sign on to the website, nisaresearch.org, and be able to register on it. You can also follow NISA on LinkedIn, and you will see the link to register for this conference and then submit an abstract if you can. Thank you. Go ahead.
Thank you, Prof. Thank you so much for bringing our attention to the NISA conference in August. So there's a question for Enola. It says, how will you describe intervening variables such as organizational readiness, implementation climate? Are they mechanisms or mediators?
Can you, I'm looking for it in the chat. Can you repeat the last part?
I'm sorry, it's answered.
Okay.
There are two questions there. The first says, what is really the gap between available evidence and implementation? And then when you open the menu up, you see the second question. There's, how will you describe intervening variables such as organizational readiness, implementation climate? Are they mechanisms or mediators?
That's an excellent question, and you're going to learn more about that when you have Dr. Ahrens on the line. I think that, in my thinking, I referred to multiple levels at which implementation occurs, and influences, determinants, and strategies, and even outcomes are measured. So I think of the organization as an important level for capturing and analyzing the key factors in implementation. For instance, we can have implementation strategies that are targeted to the organizational level. This could be a champion, it could be changing the practice infrastructure, it could be motivating, it could be enabling leaders. So I think of the organization as the where, and that we can collect data at that level, we can analyze at that level, we can get input at that level. There are some challenges in terms of aggregating. Where do we get our data? It comes from individuals. There are many challenges with aggregating individuals into a single measure of the organization. Who you choose to talk to at the organizational level. Is it a key informant? I have found that many different actors within an organization have different experiences and therefore different perspectives, and therefore who you ask may determine the answer. For instance, I once, when we were piloting the ERIC survey, I did a pilot study within an organization, and I selected 2 to 3 people who were frontline providers, 2 to 3 people who were clinical supervisors, an organizational leader. And I found that they had radically different perspectives on what strategies were used. And at first I thought, okay, maybe this questionnaire is not valid because I'm getting so much variation. Then I realized that the source of the variation was the role in an organization, and that frontline providers were using strategies that the leader did not know about and didn't need to know about. And conversely, the leader was using implementation strategies often related at the payment or the contractual level that individual providers didn't know about. So we have to be very careful in capturing information from various participants within an organization and realize that they see things differently. And that's okay. That's actually quite valid. And therefore, it complicates the measurement of what's going on at the organizational level. And I see Dr. Ahrens has his hand up. He is the expert. He can correct everything that I just got wrong.
Everything you just got right, Enola.
Oh, okay.
Thank you. But I will say this idea of levels becomes super important. And, I've done a lot of work at the organizational level. And in the last number of years, I've become a little frustrated because what we were trying to do with helping organizations develop that climate and support for implementation wasn't necessarily aligned with what was happening at the policy level, at what's funded, at what's supported by policy. So one of my current grants is working in the US with a state where we're working with organizations to develop leadership and climate, but also with the state health authority and health insurance organizations to align their policies and sort of quality metrics with what's going on at the organizational level. So yeah, there's ways to, I know people were asking about policy earlier on, and this alignment of policy and practice is important. And I think with the work in Nigeria in particular, having collaborators with the ministries of health, for example, like we do, is important in thinking about how this fits with differences in the local context in the different regions of the country. So I'll just stop there. And I also noticed there's another hand up on the attendees.
Yep. Oh, okay. There's one more question. And Greg, since you're here, it'd be good to also give your thoughts on it. It says, considering patients and families are recipients of health interventions, how have you seen their perspectives included in health-related implementation science studies? Would this represent an opportunity for using an adaptive design? Has the need for the patient-level experience come up among the ERIC expert panel? So, Enola, you two, your thoughts on this?
Yeah, I'll take a stab at that. Certainly, I think implementation science has given insufficient attention to the consumer, the patient, the user of our services. I think the earliest eras of implementation science focused almost exclusively on individual providers, to the neglect of the organization, to the neglect of the concept, of the context, and to the neglect of the users of services. Many of the implementation outcomes that we have promoted and identified and are doing research on are very relevant at the, I use the word patient level to include all of those users. For instance, we had so many illustrations of this during COVID. If masking was not feasible for individuals, it wasn't going to happen. If social distancing, for instance, in crowded housing areas or those who rely on crowded public transportation vehicles, that was not feasible. So it wasn't going to work. There is a movement to identify and classify more implementation strategies that are called patient-facing. And there are two types of patient-facing. One is that we try to influence patients. The others is that patients try to influence providers. In the example that I gave earlier about evidence-based care is out there, ask for it. We need promotion initiatives to help equip people to demand better care. So we need to enable communities to demand higher quality care from policymakers, from community leaders. This is an area for a lot of future development, and I appreciate the question for providing an opportunity to advocate for that.
Okay, thank you so much, Enola. There's a hand raised. Can we get Dr. Wolude? Can you type your question in the chat, please?
I would try to finish question in the chat before we go to hand raised, please.
Yeah, there's 2 more questions there. I think it's for John. It says, when you use the VIA method, what next do you do? So I'm not too
Oh.
sure. I think because you mentioned, yes, the stuff.
Yeah, that was, we used the VIA method and cervical cancer as just an example, but I mean, it depends on what you see from VIA. That is left to the nurses and the doctors. If it's something that is treatable immediately, they treat it with thermal ablation. If it's not something that is treatable, then they refer, right? So it's just an example.
Okay, then another question says, how do you measure levels of intervention implementation strategies that produce the level of change defined by organization or best practices as acceptable? So I guess they're trying to say, when you use an implementation strategy, how do you measure the level of change that it has produced? I think that's what this person is trying to say.
Oh, okay. So, I mean, that's the whole essence of identifying what the mechanisms are, right? Because each strategy is supposed to target a specific determinant. So if you know what strategy is targeting what determinant, then you'll be able to measure, right, what mechanisms, how did that strategy lead to that change? So that is the whole realm of identifying the mechanisms and how those changes occur. And those are the next level of work that is being done in implementation science now. So because it's not clear, that's the whole essence of the black box that we are trying to unravel, right? How do these strategies lead to these changes specifically? And that's why what we try to do in our team, right, is to document the process. What did we do? How did we do it? That process needs to be clear. It's not just enough to say X led to Y. How? How did we do it? What were the processes? You know, so that we can capture all of those intermediary outcomes and processes.
One of the things we use, I think, Enola, you can, because this is important for us to understand, is the use of mediation analysis to be able to really, because when we did, for example, in one of our NIH-funded study we did on the baby shower, which was done in churches and how to get the priest involved in HIV screening. And one of the things we did was there were different sections of the grant. There were different implementation strategies we used, whether it was the baby shower, the baby reception, the prayer session. But we went on to do a mediation analysis to say how much did each of these individual implementation strategy contribute to the outcome that we see. Not a lot of statisticians do this very well. Right. So you really have to find the statistician. I have not found any other person since then. So I would be happy to know, Greg, if you have anyone that actually does this. I've been looking. That statistician was so good, how he did the mediation analysis and be able to put those different, almost like weighing the strategies and saying how much did they contribute to the outcome that we saw. And for example, one of the things we did in the implementation strategy initially was we had a mama pack, and the mama pack was given from the priest to the woman in our original design. But they changed that halfway and used, instead of giving it to the woman, they gave it to the male partner of the woman to give the woman. And you would think this is a simple adaptation, but what he did is shut up our male involvement to 83%, because the males has to be there to receive this gift from the priest to give it to the woman. So we were thinking of how to get the men involved. So even though this was an intervention that was addressed to mainly targeting the pregnant woman, we ended up getting the highest improvement in the engagement of the male partner just by changing that strategy. And we could identify specifically what change in strategy led to that. So I think I still want to hear from both of you if there's any statistician you know who can do that work very well of mediation analysis, of looking at the components of the strategies to see either a weighted, how much they contributed or how they contributed. Thank you.
Yeah, I think Greg says in the chat, there's someone in UC San Diego that can do that.
Okay.
Okay, so we're down to our last question and our last 4 minutes for today. And the question says, I don't know what's right, but it says, can this strategy be used in other engagements like peace building? If yes, how? So I'm not sure what strategy they're talking about, but I guess they're talking about implementation strategies, whether they can be used in peace building. If yes, how?
Well, I love the idea. I love the concept. And actually, I was in a conversation with some colleagues a couple of weeks ago who were struggling with challenges of implementing behavioral health care in refugee camps. And the person said, really, the strategy we need is to stop war. If we could stop war, we would not have refugee camps so widespread, and then we would not need to direct our implementation there. So my hat's off to you for suggesting it. I must say, you know, I don't know how to bring about world peace. That should be the rallying cry that unites all of us.
Yeah. Thank you so much, Enola. Thank you, everyone. Just a quick reminder before we leave that tomorrow we have a presentation by Dr. Marcia Ori and Dr. Babayemi Olakunde. They will be talking about the use of REAIM in implementation research. The time again is 4 p.m. to 6 p.m. tomorrow, Tuesday. So we expect to see you tomorrow again, and we want you to share the information with the other colleagues and friends who would be interested to join us. And just as we wrap up, I'd like to ask the director for the Center for Translation and Implementation Research, Dr. Ezanobe, to speak to us.
I just wanted to use this opportunity just to, again, encourage people. Yeah, if you can send us an email, the email is on the chat box. It's just for us to see what other topics and implementation science will you like to hear. So we are beginning to prepare our last NISA Research Week for the year, which will happen in November. And then, so we are trying to see what other topics that you would like to hear about. So as you attend these meetings, think about how they have helped you, but think about other topics that you would like to hear about. We are also looking for local investigators who will be interested in co-presenting, so that as we get the topic, we'll put those topics out, and then we will have local investigators who have contextual information to be able to co-present. Thank you, and we're also looking at ways to improve this. So any suggestion you have, please, you can send to the email. It will be useful to us. Thank you all so much for attending, and look forward to seeing you tomorrow. Thank you.
Thank you, guys, and see you tomorrow. Bye-bye.
Bye.